Endoscopic Management of Ampullary Tumors, European Society of Gastrointestinal Endoscopy, ESGE Guideline. Introduction. Ampullary tumors are increasingly diagnosed nowadays because of better accuracy of gastroscopy and endoscopic detection technologies. Endoscopy has an important role in management of these lesions, particularly in a curative setting. Nevertheless, diagnostic and therapeutic strategies have to be clearly defined. This guideline does not discuss ampullary and duodenal lesions associated with predisposing genetic syndromes, including familial adenomatous polyposis or lesions of submucosal and neuroendocrine origin, as they are considered in another guideline from the European Society of Gastrointestinal Endoscopy, ESGE. While the indications for endoscopic treatment and follow-up may be different between the sporadic and polyposis-related forms, the statements regarding diagnosis, evaluation, technical modalities of endoscopic papillectomy, and management of complications are similar. Furthermore, while the majority of ampullary lesions involve the major papilla, the recommendations in this guidance should also be applied in the case of a tumor of the minor papilla in a patient with a pancreas divisum. Main recommendations. ESGE recommends against diagnostic and therapeutic papillectomy when adenoma is not proven. Strong recommendation, low-quality evidence. ESGE recommends endoscopic ultrasound and abdominal magnetic resonance cholangiopancreatography, MRCP, for staging of ampullary tumors. Strong recommendation, low-quality evidence. ESGE recommends endoscopic papillectomy in patients with ampullary adenoma without intraductal extension because of good results regarding outcome, technical and clinical success, morbidity, and recurrence. Strong recommendation, moderate quality evidence. ESGE recommends en bloc resection of ampullary adenomas up to 20 to 30 millimeters in diameter to achieve R0 resection for optimizing the complete resection rate, providing optimal histopathology and reduction of the recurrence rate after endoscopic papillectomy. Strong recommendation, low quality evidence. ESGE suggests considering surgical treatment of ampullary adenomas when endoscopic resection is not feasible for technical reasons such as diverticulum or size more than 4 centimeters, and in the case of intraductal involvement of more than 20 millimeters. Surveillance thereafter is still mandatory. Weak recommendation, low quality evidence. ESGE recommends direct snare resection without submucosal injection for endoscopic papillectomy. Strong recommendation, moderate quality evidence. ESGE recommends prophylactic pancreatic duct stenting to reduce the risk of pancreatitis after endoscopic papillectomy. Strong recommendation, moderate quality evidence. ESGE recommends long-term monitoring of patients after endoscopic papillectomy or surgical ampulectomy based on duodenoscopy with biopsies of the scar and of any abnormal area within the first 3 months, at 6 and 12 months, and thereafter yearly for at least 5 years. Strong recommendation, low-quality evidence.